we've got the extra mile winners for the summer. And we have, hopefully, I haven't seen it yet, individual winner, Sally Talbot. Come on, show your face, please.
I'm here and my camera's on.
Oh, is it? Hang on, you're on about page 3 of my... Oh, there you are, yeah. Sally, this is the nomination that was given for you, which is you've been given this because of your outstanding leadership and compassion and dedication. I have to say, comments are you go above and beyond to support both team and pregnant people across Warwickshire. Working alongside Sally has not only given me back my passion for midwifery, but also given me my life balance back. She inspires her colleagues through approachable, caring nature, and embodies the trust values by being safe, effective, compassionate, trusted, inclusive in everything she does. And finally is this one. She listens to my ideas and suggestions and is always so positive. I feel totally valued with her as my manager, and I hope she knows the difference she makes to her team. I suspect you'll be able to work out who that is, but that's a wonderful thing for somebody to say, isn't it? All I can say is, Sally, well done, congratulations, and you are an example for all of us to follow. And I think we should give her a round of applause, please.
Thank you.
No problem, Sally. And moving on, the team award, and I wonder if they've managed to get any more people in the picture. Yeah, fortunately, Sally, you were the only one in the picture at the time. Your colleagues in the ED department seem to have crammed everybody that's on duty at the moment in the picture. And all I can say is that the nomination for this, you're recognised for exceptional teamwork, efficiency and compassion in caring for patients. And in particular, one patient who clearly wasn't terribly well at the time said, your staff are all kind and wonderfully attentive. I want to say bless them. They take away the fear and calm me down. And they added, the doctors had great patience in explaining what was happening, which helped to turn a frightening situation into one of reassurance. All I can say is very well done to all of you. And thank you for doing that and continue doing that in the future. So another round of applause, please. And thank you for that. And I do think it's unfortunate we're not doing these things in person, because it would be much better. Although I suspect for the ED department, we wouldn't have a big enough room because they all want to be there. So thank you for that. You can choose to stay if you wish, all of you, or if you've got other things to do, by all means, go elsewhere. I'll leave you to decide. Thank you. Moving on a bit, apologies for absence. Sarah?
So we've got apologies from Russell, and obviously you're chairing David in Russell's absence. Also apologies from Yasmin, Baskar and Barty.
Thank you. Any declarations of interest that we need to hear about? Haven't already been declared. No hands. Minutes of the meeting in July. Any errors of fact there? Ollie.
Sorry, just I was a little bit slow on raising my hand. I've got a new declared interest in the register.
Okay.
That's okay. I've got a new declared interest in the register, which is that my partner works for Compass Group as an accountant.
Okay, thank you for that. That will be duly recorded. So going back to the minutes of the meeting, the 2nd of July, any errors of fact? See none? That can be duly accepted. And the extraordinary meeting held on the 6th of August. Any? No? And if we go to the matters arising or actions update, the majority of these are complete from what I can see. Tell me if they're not. There's one from Fiona that's complete, I know. Then there's another one from the Chief People Officer, and Harkamel, which is they're both complete. Free to speak up, complete. And I think all the others are complete, other than, from what I gather, the last one, which is there's one that's going to be on the board agenda in October, if I'm correct. And Adam's including the last one in his board report. So anybody got any other matters arising? Move on. No? Thank you for that. The minutes of the Foundation Board meeting and the actions log are largely just for information. There's clearly they're only draft until the board meeting, the Foundation Group board meeting in November. Regarding my comments, this morning we had a fascinating workshop, and it started in a way that I think all days should start. We had 5 minutes of meditation, which those of us that were there and experienced it, I have to say I didn't know what to expect, but I was extremely pleasantly surprised. So perhaps we should have that on our workshop agenda every month, but perhaps that's for another discussion. We then followed it up with a patient story relating to a child in crisis, and this was pretty emotive, I have to say. But pleased to say there was a successful outcome, largely due to the dedication of our staff. So I think that, and I think it meant a lot to a lot of us, that one did. We then followed it up with partnership, really about partnership relationships within the system. We had a discussion about a new tool for hospital development, which was caused some frightening end results, that if we do nothing, we might need another 220 beds, which I think surprised many of us. We then had an update on the emergency department development, and we've ended up with a cancer services update. I don't think anybody wants any other comments on that from me. Perhaps we should then move on to the next agenda item, which is the annual review of standing financial instructions. I think that's you, Kim, is it?
Yeah,
No.
Thank you, Chair. So this is the annual review. We've already taken this through our audit committee, and we've highlighted the key changes for you to note. I think the key ones to pick out is around the fact of the scheme of around which one, section 9.4.5, around quotes and competitive and non-competitive quotes, around all tender evaluations for revenue exceeding £500,000 per annum or over 2 million over the contract life will require approval by the board of directors, with the exemption of new revenue, which that exceeds over £500,000, and that will also require board of directors approval. So just wanted to highlight those really for your for you to note. And all the rest is obviously set out for you to note. So really, I'm just asking for the board to approve these proposed amendments and scheme of delegation. Thank you. Sorry, my phone's ringing. Apologies.
Anybody got any comments or observations on this? No. Are we happy to approve them? Please put up your hand if you're not willing to approve. See no hands, so duly approved. Kim, thank you for that. If we can move on, winter plan, vaccination plan. Harkamal, or is that Fiona? I don't know which of you is talking on that one.
I can start off and then Fiona can add.
Okay,
Is that,
fire away.
So this is our annual plan for this winter for SWFT. And it's designed to help us manage the pressures that we are expecting to face over the coming winter, with an aim to obviously keep our patients safe, support our staff and maintain the highest quality of care. We have built this plan based on what we've learned from not only winter last year, but also all of the seasonal pressures that we faced in previous boards. I think I've talked about just how busy this July was, for example. So we've got lots of experience here of managing unexpected pressure, and it's with that in mind that we've developed this plan. In the document, you'll find the modelling that we've prepared, which has included many different scenarios to try and model what this winter could look like. so that we can plan our bed surge capacity as closely to what the likely case scenario is as possible. And you'll see all of that detail in the plan that I won't necessarily go through. But I would just like to pull out the fact that we are expecting this to be one of our most challenging winters ever. At the moment, we think that we will have a gap of 78 beds. If you think we've got about 400 beds in circulation for medical admissions, 78 is really significant as a proportion of that. So it feels challenging. We have a winter planning board here, which is attended by a multidisciplinary team, and that's regular. We also have our daily silver meetings where we talk about any other issues or lessons learned that we can put into this. A really key part of the plan is the vaccination programme, and that's going to run from October to March, and the aim is to improve our uptake from last year's 43% to protect our staff and our patients. But as a key part, I'd like to pull out of the plan. I think the vaccination bit is really important. We've also included details of our infection prevention team, how they're going to work, how they're going to monitor our outbreaks, because we know that infection rises. And we've worked with system partners on how we can work best as a healthcare system to try and manage some of these surge scenarios that we're expecting to see. We've got a board assurance framework that we've also completed, and this board has seen this plan. So I hope if anyone's got any feedback, you'll obviously let me know. I am the designated winter director. So we'll be aligning all of our responses and working closely with our system partners. And then finally, within the plan, as an appendix, I've included our tailored safety plans by division to ensure that we can respond quickly and effectively.
Thanks, Harkamel. Nothing to add, Fiona, to that, I presume?
No, thank you, Chair.
Thank you. Anybody got any comments or questions? Anyone from me with the vaccinations? I presume we are hoping to do better than last year with staff vaccinations. Have we got any lessons we learnt last year that we've managed to put into place this year that will perhaps improve those vaccination rates?
Yeah, I think there was a real apathy last year in relation to vaccine generally across the public, wasn't it? And we were actually better than peers at 43%, although prior to COVID we were more like 80%. So we've been set a 5% increase target as every provider. I'm hoping to get more than that, but that's our target that's been given to us by NHSE. I think one of the learnings and what is detailed in the paper is how we have put some additional resource around it. So we generally use peer vaccination a process. So nurses, therapists that want to help are trained in giving vaccinations and supporting their teams to have that. That's worked to a degree, but previously also we've relied heavily on occupational health, and we haven't got that this year. And so we've needed to put some additional resource in terms of a lead nurse that can coordinate the peer vaccinators and, you know, do a percentage of the vaccinations herself. And that's being managed through the matron team. So I'm confident that we will get to the compliance that we got last time. Whether we'll get higher, I don't know.
Yeah,
Really
I have to say 5% improvement is not exactly ambitious, is it? Really, given where you're starting, and we were better than peers, right? That's even worse, isn't it? For the yeah, Adam.
Thanks, Chair, and thanks to Harkamel and Fiona for their work on the plan. I think it's also worth noting we're not part of our plan; it's part of the systems plan. There is concerted additional work on the public vaccination campaign this year, and the ICB have set aside funding to particularly target vaccinations to communities where take-up has been low in the past, and they're implementing various interventions to support that. I think it's important to remind members of the public present and watching this meeting that the vaccine program is the best way to protect yourself from seasonal illnesses. It helps keep you out of hospital, and you don't want to be in hospital in the winter. So we would commend getting a vaccine to all those able to do so.
Yeah, and of course all of us on the board will be having our vaccinations, won't we? So that's we will lead by example. I certainly shall. Anyway, anything else on this? No. So are we happy to approve this this plan? Again, hands up if you don't approve. Duly approved. Moving on. Acting Chief Executive report. That's over to you, Adam.
Thank you very much, Chair. So a report I'll take as read, but a few things in particular to highlight. Board members and members of the public will be aware that back in May we announced our plans to move to a shared leadership team, and that work is moving forwards, and we'll talk about that more over the coming weeks. I think one of the really important things to note is this will be the last time we meet as a single SWFT board. And so from next month, from the 7th of October, we intend to meet as a joint board representing both SWFT and George Eliot Hospital. So that meeting will take place on the 7th of October. A few other pieces of good news to update on. The Ellen Badger Hospital opened in June, as we've previously shared here. I think it's a fantastic development. The new building provides a health and wellbeing hub on the ground floor, outpatient services on the first floor, and on the top floor a base for our community teams and for Shipston Home nursing. We're also currently working with the ICB and Shipston Medical Centre to fit out space on the first floor for additional consulting rooms for them. So there'll be 10 consulting rooms and 1 treatment room for general practice. And the building work will complete at the end of October, and then they will commission and move into that space. We're also planning a pilot of a medical day case unit at the Ellen Badger Hospital, which we intend to commence from October. I think it's a really fantastic facility. It's we've seen some of this before in Lillington, where we co-locate services, primary care, community services and wellbeing voluntary sector services in one place. There are a tremendous number of benefits from sharing and working together. So I think this will be a fantastic facility for the community in Shipston and beyond. Also, I need to mention the elective hub on the Warwick site, which will open later this month, or a ground floor of it will open later this month. And again, a fantastic development. Thank you to Sophie and her teams and our wider estates teams and colleagues who put so much work into getting those facilities designed, built and commissioned. The report, I've included the annual report for volunteering with my report this month. Volunteering is incredibly important to us as an organisation. I think across the NHS, the value of volunteers is often under-recognised, but that is certainly not the case here. We absolutely value the role our volunteers play in our daily business. We've got over 650 volunteers, or we had 650 volunteers over the last year, which was an increase of over 100, and they contributed over 30,000 hours to the trust. And that, I mean, that's really fantastic. Volunteers do all sorts of stuff. They help people around our buildings. They help with classes for recovery. They bring in therapy dogs to our wards and so on. And what we constantly hear from our patients in feedback and indeed from our staff is that the roles volunteers play in our day-to-day business helps their recovery, helps them feel more comfortable in our services, and helps us do our day-to-day work. So thank you very much to volunteers, and I would recommend reading that volunteering report, because it does much more justice than I do to the fantastic work that volunteering does for the trust. Finally, in the More from Great Teams section of the report, we highlight our knowledge and library services. So this is a service that formed in October 2021 jointly with George Eliot. They've had a recent successful quality and improvement outcomes visit with NHS England, which really highlighted some of the great work of that team. We also consistently get great feedback from users of that service. Again, knowledge and library services is a service that's value isn't always recognised, but they do fantastic work for us. They provide resources, they support literature reviews, which really helps in our decision making, and of course they provide space and facilities for our staff. So I'd commend knowledge and library services to all our staff. That's key points from my report this month, Chair, but I'm happy to take any questions.
Anybody got any questions about them? Everybody's fairly subdued this afternoon. Oh, Sophie.
Yeah, not a question, just a build really on a couple of things. So the elective hobby is brilliant. You know, I know a number on the call have seen it. It's been a long time coming. We have had like some delays through the kind of navigating we're doing with our retail partners. So through no fault of our own in a way. So really will be great to get that open next month. And I was just going to reference, I know it says it in the small print, but I think the site walkarounds, just would want to give assurance really that we all do a lot more than what's on that table, because I think it's going to be really important in terms of like that shared leadership team as well. So it was just to give a bit more assurance around that, because it's in the small print, but I think just noting really that I know a number of non-execs and execs go on those walkarounds, and we maybe need to think about how we present that.
Good point. The other points on this? Thank you for that. Then Adam, moving on. Oh, right. Sorry, it was in the, somebody came up in the chat from Mike, trying to remind us that something else opened in June in Stratford. If we can move on then, integrated performance report. I think we're starting with you, Fiona. I think, are we, on these quality and safety?
Yes, unless Adam, were you going to do a summary now?
No.
Okay. So yeah, from a quality and safety point of view, I'm pleased to say that the majority of the quality focused KPIs are within normal range or above expected target, with the exception of a few which I've just pulled out. So our falls data, although we've had a reduction in the number of falls, we have seen an increase in the harm level of related to inpatient falls at the moment, and we are just unpicking that. It could just be a trend in month, and it may go back down again, but we have had some incidences in the last month that have caused harm. Obviously they go through a harm review and investigation to learn the lessons from those, and we'll make sure that any learning is implemented and across the trust to make sure our patients are safe from falls, but just referencing that there. In terms of complaints, although we've seen a slight decrease in the number of complaints in the quarter, the response rate is still a worry. And that is because, you know, if a patient or a relative has taken the time to send in a formal complaint, either by letter or email, we should be agreeing with them how long it's going to take us to investigate and complying with that response rate, and we're not quite there at the moment. So we are doing some improvement work, particularly around what our complaints policy is, how we distribute them across the organisation, recognising people's workload and time that they've got to investigate these. Ensuring that the clinical teams own the majority of them, because it is a patient experience concern, but also that we're also taking some mutual aid or support from George Eliot in terms of how they manage complaints and learning some lessons from them. So we're doing some improvement work in the background, and I'm hoping that that trend will improve on the back of that. Similarly, friends and family test, although 92% of our patients report a good experience in our services, we still have quite a low number of patients and relatives actually filling in the friends and family test either online or on paper. And again, we're doing some detailed work with the company that provide this service for us, but also again with the matron and ward manager team, just understanding and community teams understanding how we can encourage people to complete that survey. It's really valuable to us in terms of our feedback and narrowing down where we need to do our continued improvement work. So again, encourage the public to give us feedback on their experiences. And then finally, some good news. Our VTE risk assessment compliance has significantly improved in the last 2 quarters, and that you can see that trajectory there on page 6. That's really down to our medical director or chief medical officer and his deputy that have really championed that with our clinical colleagues in terms of making sure that they're aware of the safety risk around that risk assessment. So I thank Bhaskar for that. Thank you.
Thank you, Fiona. Any questions of Fiona on this? No. I mean, I would agree. It's been the VTE performance has been a dramatic improvement, isn't it? And like you, I'd commend. I know it was a lot of work that Bhaskar had done that actually made the difference there. Okay, moving on then. The HarkerMel, its performance.
Thank you. So really pleased to share the September the highlights in our September board report, which represent July's performance. Starting off with our really encouraging progress in the emergency department. So the trust achieved 78.8% against 4-hour standard, which is our best result in over a year, in terms of slightly exceeding the national target. And I'm really proud of that because July was one of our well, it was our second busiest month we've ever had here at SWFT. And Stratford also peaked in terms of attendances, and that just under 500. That's the highest that we've seen since post-pandemic reopening, which is really, really encouraging. Our ambulance arrivals averaged 53 a day, and we did see a small spike in 60-minute handovers at the very start of the month, driven by that demand. And 30-minute handover improved, and our average was 15.2 minutes, which is better than our planned target. And overall, we remain really exemplar in terms of our ambulance handover times, which I'm really, really proud of. From a length of stay perspective, that did improve in July. The acuity was slightly lower, as you would expect to see over the summer. So that was represented there. And our emergency length of stay dropped to 6.4 days, which is really, really encouraging to see. From an IPC perspective, infection control perspective, though bed closures related to that reduced, which again you would expect to see in the summer. From a diagnostics performance perspective, our performance reached 98.3%, and our waiting list actually shrunk for the first time in most areas. We have still got some thorny areas of pressure, so audiology, cardiology, and echo and urodynamics are below target. But we've seen real progress in those number of patients waiting over 13 weeks, which is a really significant improvement for us. And within my board report, I have included a focus slide on diagnostic performance, not least because I think diagnostics is often a bit sort of unsung. We talk about an increase in referrals and we get busier in A&E, and I think we don't always triangulate what that means for the rest of the hospital. And diagnostics really is one of those areas of growth across the NHS. So I've just included a little bit in terms of like as a focus slide around what our performance has been. And you'll see that whilst we had quite a dip last year, we have started to improve again. And then just talked a little bit about what some of our action plans are, because I feel like that's quite important. Finally, our 2-hour response in the community remained really strong, and there's been a slight shift in our in the birth delivery modes in maternity, and our total births did rise to 291, which was up slightly from the 280 in June. That's how busy we were.
Any questions? Robert?
I was just looking at the bottom of page 9 of 24 on the, it says maternity services saw a shift in delivery modes. Were those stark increases and decreases? Is that kind of following a particular trend? Are we high where elective cesareans are concerned?
We don't benchmark in the same way that we used to. So in terms of pulling out what those comparisons are by delivery mode, we don't necessarily benchmark, but just because of the complexity around our population mix here compared to other organisations. But it was just to note that actually it is a decrease in vaginal births and a very slight increase in cesareans. I don't know if Lorraine or Fiona have a view, but there's nothing that exposes us to any risk. We're not necessarily an outlier. It is just a shift, and we agreed that moving forward from board presentation, we would just note what the delivery modes are, and then if there is any risk as a result, we would pull that out. But you're right. I think the way I phrased it sort of suggests something a bit more significant. Lorraine, I don't know if you.
Lorraine's going to help you out here.
Want to help me out?
Thank you, Harkman. Although you explained that very well, so we obviously we get exciting you on that. Obviously, following Ockender report, we removed the benchmarking for cesarean sections because there was that focus around concerns low birth rate birth compared to cesarean sections. So we don't technically benchmark, we don't have to report on that, but it's important that we as an organisation just look at our themes and trends. We know from all the work that we've done, we do have a higher cesarean rate here, but that is because of some of our comorbidities, so increased diabetes, BMI, maternal age are some of those contributory factors to that. But so we keep an eye on that, but we don't have to report on that. But it's just important that we can see from our theatre capacity utilisation the increase that we have in our theatre activity and impact that they may have on the service.
Okay, thank you. That's helpful.
Yeah. Lorraine, I don't know whether we should be doing it in this section, but we may as well, since you brought that up. I mean, this clearly it's a measure of the increasing complexity of the deliveries, isn't it, that's causing this rise. The impact of that obviously on the department could be quite significant, and I just wonder how much is actually transmitted above about this and how much notice is taken of this, because clearly the complexity that we're seeing now in maternity is not what this unit was designed for.
Yeah, absolutely. And as you know, one of our highest risks is around our theatre and the capital that we've got to increase that, although we know even when we have that refurb done, it still won't make our theatres what they need to be for the workload that we have through there. But it does have an impact on our workforce as well, and the number of women that we were seeing coming from out of area for cesarean sections, but with our acceptance criteria now, with that's reduced. But it does have across the workforce or across capacity, etc. It is significant, and it's one of our highest risks around our theatre capacity at present.
Yeah, thank you for that. Any other ones? Fiona?
Just to add to that, really, it's not only space, is it, and theatre capacity. You know, obviously, when they go to being a C-section, that is a medical intervention, and so the obstetric workforce is impacted. Whereas if it's vaginal birth and midwifery led, then we know that we can recruit midwives well and we retain them well, and we've got a strong workforce there. But there is some fragility around the obstetric team.
Yeah, absolutely. And also to add, the length of stay is longer, so actually it does impact on our discharges from Swan and that capacity we have throughout the service. So yeah, it absolutely does have an impact across all areas and services within maternity and wider as well, because it's not just, it's anaesthetics and paediatricians as well that we need to support us with cesarean sections.
Thank you. Any other questions for Harkamel? No? Okay, moving on, workforce. Ashi, and welcome, Ashi. I think this is the first SWIFT board, and maybe now the only SWIFT only board you ever go to. Welcome, Ashi.
Thank you, Chair. Great to be here. So yeah, if I just pick out some of the key workforce highlights from the report. So recruitment remains in a really healthy position, and we are very efficient in our recruitment processes. So you can see there in terms of some of the KPIs around our time to hire processes are very positive. Sickness remains one of our big key risks, and you can see a slight in-month increase in sickness, but that has been the trend over the last year, and we are above that 4% target. So although there has been a reduction in sickness in the last few months, that tends to be the trend as we come out of winter. So obviously very conscious of that potentially increasing. The report does go through some of the actions and interventions that we are taking, working with our staff and divisions, particularly around supporting managers and staff with their sickness on a short-term and long-term basis. And some of the other actions we'll be looking at is the occupational health provision and really ensuring that that works for us. There was a lot of work being done on the attendance policy, and I know people are very keen to see that new policy come out, which again I think will be able to support our management staff. And then also some of the wider intervention and support from our health and wellbeing teams, EDI teams, and also Free to Speak Up, which I think supports the wellbeing agenda there. But yeah, sickness does remain one of the key risks for us. From a turnover perspective, so although there has been an increase in turnover, nothing significant, and remains under our 10% target. And we're also in a good place in terms of our compliance with mandatory training. We have started to see a dip in our appraisal compliance, and we are just doing some work in the background to understand why that is. It might be to do with the new Swift Learn system that's been implemented. And although that will have greater benefits in the long term, I think there's probably some teething problems there in terms of managers using the system and updating the system with the appraisals that have taken place. So that's something we are working through. But those are probably the key highlights I wanted to take, Chair. So yeah, happy to take any questions or comments.
Bill.
Obviously a very warm welcome, but what are your first impressions?
Well, firstly, the fact that I have been welcomed so much from the trust and our staff has been amazing. Able to see a couple of the tours of the site. So I went down to Stratford, obviously looking around Warwick as well. So really feel welcome, Phil. Picking up on some of the issues and risks that are known to the board, which I'm working through, and also it's really good from my perspective in terms of that joint role with George Elliott as well. So hoping to bring some of the collaboration work together, and that's something obviously as a single leadership team we'll all be doing. So, but yeah, very positive, Phil. Thank you.
Oliver.
Thanks, yeah, and very warm welcome as well. But just curious, you're talking about sickness and absence and coming from the outside. Just curious what you think we should be doing, because it's been consistently higher than target. So what your initial observations are about what we could be doing more than we are on that.
Sure, thank you. So I think first of all, to acknowledge the challenging climate we're all working in across the NHS, and this is an issue for us locally in obviously at Swift with our partners in the foundation group and nationally. And so any support we can be giving to our staff in terms of working through their challenges, which obviously does impact on their kind of health and well-being, is a national issue for us. But certainly in terms of, I think, the work we can be doing in Swift. So I've witnessed and seen so many interventions and offers from a wellbeing perspective, which are really amazing that this trust offers. And perhaps there's something more in communicating them so staff are aware of them. But I think one of the biggest issues also related to people's wellbeing is that relationship they have with their managers and that pastoral care. And that needs to be a really caring, meaningful relationship. And again, on the whole, I'm hearing it is, and that's brilliant, but there will be pockets where that could be improved. And we need to equip our managers to also be able to manage and support staff as well as supporting our staff. the report does detail the top 3 reasons for sickness, which around stress and anxiety, MSK problems, and gastrointestinal issues. So again, I think there's much more we could be doing from certainly the stress, anxiety perspective and the climate people are working in. And then also, as I mentioned, really making sure our EAP offers and our occupational health service really works for us and helps get our staff back to work. So I think there are still areas that we can go at, Oliver, in terms of improving things for staff.
Right, no, that's really helpful. Thank you.
Actually, on that point, actually, I mean, we're consistently with our own self-imposed, I presume, trust target for sickness. How do we benchmark against trusts across the country, or don't we get that data?
Yeah, we can and that's something we can definitely provide to the board in terms of the benchmarking. So generally across acute and community sectors, you tend to see a KPI of around 4%, which is consistent with ours. Obviously, I come from a mental health and learning disability background, and certainly you expect sickness absence to be higher than that due to some of the kind of the issues on inpatient wards, but certainly across acute and community sectors, I think our KPI is the right one. But as I said, nationally, we are seeing other trusts also having a higher sickness rate. But I can bring the benchmarking to what is that?
Yeah, I mean, it's sort of the point I was getting at really is that is this wildly adrift of our peers, what we are at the moment, or are we much as we'd expect our peers?
Yeah, I can bring that back so we can see where we benchmark against the foundation group and then more nationally as well.
Sure. But I think it's worth acknowledging, as you have done, that there's an awful lot of work within the trust to support the staff and well-being. And this possibly is just a reflection of, the intensity of workload here and similar places. Any more comments about workforce? No? Should we move on? Financial performance. Kim.
Yeah, thank you, Chair. So the month 4 position, we are off plan. Unfortunately, we're reporting a £2.6 million deficit against a £1.8 million deficit. So I think it's really important really to understand really the challenging financial environment that we're currently working in, but also the challenging operational environment that we're operating in that Harkamal's already highlighted. So we've obviously got plans in place in terms of ensuring that we're back on track, and we've got the Excel in Everything, which is our CNIP programme, which I'll talk about a little bit more in a minute. I think key thing that I've picked up on the report that I referred to was that we were still having some challenges around additional capacity remaining open, including the 12 SERU beds that the ICB had not funded for this financial year. I'm pleased to report that I have managed to secure for this year £1.9 million of funding for the ICB. So that happened last week. So I'm pleased to report that to the board today. However, we have got a challenging position to actually pull back the position. As I said, we've got Excel in Everything. We've done a reset of that meeting, and we have assigned senior responsible officers, which are effectively members of the executive team, to be responsible for each of those work streams. And they now also feed into a financial recovery board that we have set up, which is constituted with all members of the board of directors. And that meeting gives more time dedicated to give assurance around what are we doing and making sure that we are back on track. And if there are any issues that need further support, then that's the meeting where we will get more support from your collective board to actually move things and push things forward. The other things to note really is around cash. There is a challenge around cash because, again, if we continue to spend at the rate that we're doing without actually delivering on the cost improvement programme, then that also has an impact in terms of our cash position. We are doing a piece of work across the system around managing our cash as a system, because some organisations historically have got more cash than others because of the financial regime that we're operating under. So So that work is a system piece of work that actually I've asked David Moon to lead on our behalf across the system, and all system partners are engaged in that piece of work as well. I think those are the key things that I wanted to highlight at this stage. Thank you, David.
Kim, any questions of Kim? So Oliver's obviously just slipped out and coming back in. I don't know whether he's any questions at all of Kim? No. Thank you, Kim. We will move on. Quarterly safe staffing report. That's you, Fiona, I think, isn't it?
It is, yeah, thank you. So yes, this is our normal quarterly safe staffing report that gives assurance to the board that we've got really robust systems of monitoring and taking action on staffing. Both nursing, midwifery and AHPs are included in this report. We have daily staffing oversight, weekly, monthly, quarterly oversight, and taking action on any gaps. We've got robust recruitment retention procedures that, as Ashley said, and we engage in higher education and university to look at sort of pipeline and progression for staff schemes as well. So overall, I'd like to give board assurance that we have safe staffing. Where there are gaps, we've got actions being taken. Where there are risks, there's mitigation against those, and those risks are managed and managed by the divisions and escalated if need be. But happy to take any questions.
Any questions of Fiona? One from me relates to the risk in ED regarding paediatric nursing expertise, shall we say. I can see that there's quite a few mitigations here, which is obviously good, which keeps us safe as such. But I just wonder how successful are we likely to be to recruit? Because clearly we need people actually permanently in post to fill this. Do these people exist to actually recruit? It's probably my main question, because I presume everybody else is fishing for the same people.
Yeah, registered children's nurses are a limited group of staff, and they are more difficult to recruit to. But although we have been pretty successful recently, and again, benchmarking, we're in a better position than a large percentage of DGHs. But and that's the reason that we've gone down the route of adult nurses having additional children paediatric competence. And I'm sure you're bringing this up because it was cited and seen as a risk within recent CQC inspection. And I think where we were not able to give assurance on to CQC was that we didn't have local registers of who had that additional training and who hadn't. So the individuals had their own competency booklet, but we didn't have department oversight of those. So that has definitely been corrected. I and you have both have visited the paediatric A&E more recently. We've sought assurance from the senior paediatric nurses to say, do you know who you can delegate tasks to, who is skilled in paediatrics? And I was very assured that they did have that oversight much more robustly now. And so we will continue to recruit as far as possible paediatric children's nurses, but actually we will also need to continue to upskill adult nurses and rotate them in to maintain their skill. If you've actually got a complete complement of paediatric nurses, the adult nurses are at risk of losing that skill. So actually having both is safer to manage any gap and be flexible and responsive to any gap going forward. We're also engaging with the university to in Oxford Brookes to dual qualify some of our nurses as well, so top up from an adult nurse to a children through a university module as well as in-house. So I'm confident that we have got a good plan and that we are safe there. Thank you.
Thank you. Robert.
I'm just looking at the graph at the top of page 5 of 24, where we're plotting maternity and nursing shortages, and then giving an indication of the number of incidents. And I guess it's showing a pattern that you would sort of expect, I suppose, that the greater the shortage, the more incidents that we may be seeing. But I just wanted to check, and this might be too detailed, and so it can be taken back through clinical governance or something. But is that would that include all of the incidents, near misses, things without harm? It's all events, is it? That absolute number? Yeah. Okay.
It is that. Yeah, there's a drop down box within the incident management system that says what is the risk, whether it was a near miss, actual harm, and what the effect to the patient was. So yeah, that can all be categorized.
Yeah, because I guess over time what we'd want to understand is if, and I'm not saying there's causation here, you've seen a pattern, but I guess the mix of what's in those instances is important over time. Yeah. Okay. Thank you.
Thank you.
Any other questions? I mean, I suppose the only other workforce question probably isn't necessarily for you. It relates to the sickness rates in SCBU registered nurses, because that's, I see, is a big risk for us, because they're even rarer than paediatric trained nurses. I'm not sure if that's one for you, Lorraine, or if it's one for Fiona. Really, it's probably a bit of both, isn't it? I don't know if you want to make any comments on that, or
happy to pick that up. I think when you've got a small unit, sometimes your 1 or 2 staff being off makes your percentage look very high, so we know that drives that. But you're absolutely right, it's a very specialised area, and there aren't many nurses that have qualified in specialty, so in neonatal care, so we do struggle with that. We have been really pleased to see that we haven't had to use agency hardly for those areas, which has been really good. But it is an area that we focus on. It's part of maternity as well, because you will see that maternity sickness is high because they're quite high pressured areas. But I think SCBU sometimes just flags because of the small amounts of numbers, but we work very closely with HR to make sure that we are supporting all our staff back to work and appropriately, and keeping them at work, which is most important.
Is this long-term sick of one person, or is it lots of people having short-term sickness?
A little bit of both. I think we saw across the summer holidays, we did see a peak in short-term sickness in maternity and neonates, but we have got a number of long-term sickness. Some staff that have got really poorly conditions, and that's driving the long-term sickness. So, but yeah, they're all being managed appropriately.
Thank you. Anything else for Fiona? No. We'll move on. So you've got the floor now, Lorraine. Perinatal quarterly report.
Thank you, Chair. So this is Q1's report for maternity and neonatal services, the perinatal services. So that's from April to June. Obviously, maternity service continues to be very busy, as we've discussed, and we're just about to peak with September and October. We know that's going to be very busy, but as you are aware, we've had lots of support from management board and trust board to look at our acuity and capacities, and we have put an acceptance criteria in. From July, that was around late referrals. After 16 weeks, we are declining, and we have seen quite a number of declines from out of area, and then obviously an acceptance criteria from the 1st of August from out of area, so outside of Coventry, Warwickshire, Beesall and Banbury. Anything else, we will be referring them back to their local units. So we will continue to monitor those numbers, but we know that our capacity and acuity is still something that we need to keep a very close eye on, and we're doing some regional work with the LMNS to look at again capacity within the system and how we can support some of those women going back to their local areas, and how we can support out of area women going back to their local units as well. It's a bigger piece of work with region, but something we're very closely keeping an eye on. Obviously, we've talked about theatre capacity, and the highest risk we've got is around our refurbishment of theatres, but really pleasing to say the management of theatres is now progressing to our theatre teams to manage, which is with that support, and that transition is going really well, and that's really supporting that oversight of theatre management. Obviously, again, we talked about workforce, so we have got some concerns around the obstetric staff, in particular around our registrar level, and we have got a business case going through at the moment to support an increase in registrars for obstetrics, because actually they do cover maternity and gynecology, so we do need to make sure that that we are sufficiently supporting that line of obstetricians. Also, we're doing some work, as we all know, with the EPR Oracle Health. Maternity has Badgernet, but we are, with the rest of the organisation, transitioning onto Oracle Health. There are still quite a number of risks for maternity services that we're working through with the teams, and the teams are attending all sessions to try and look at how we can localise and what we need to do for that transition, but we are just raising that we have a number of risks still outstanding. We've talked about sickness levels, so I'm not going to cover that back over. Our vacancy rates are really good, and we are basically, when we all our newly qualified midwives start in September and October, we will have no vacancies. I think we've talked before that there is actually a national shortage of jobs for our newly qualified midwives regionally, and so there's a national graduate process in place where they're asking maternity units to look at how they can convert some other posts temporarily to make sure that all our newly qualified midwives do get a job. I think there's about 400 midwives nationally that haven't still got a job at present, so a bit of work there that we are looking at what we can do to support our midwives. We are lucky that in this region that we only have one intake every year, so but for some other regions they have another intake that will qualify in January, which will put in more student midwives that are acquiring jobs. So, but we are in a really lucky position that staff want to come and work here, and we retain our staff really well here, and we have really good health and well-being. All our national stillbirth, neonatal rates all below the national average. You can see that we've undertaken some perinatal reviews, and there are some action plans there. So I'm not going to go too much into detail, because actually the learning has been shared and it's in the report, but we continue to share and support our families that are going through any bereavements there. The one other main highlight I want to bring from this report is around the national review that Wes Streeting declared in June, looking at maternity services. So Baroness Amos has now been appointed to undertake this review. She's just getting her team together and doing the terms of reference, and there will be 10 organisations that will be part of that review. We don't know who they're going to be yet. But there was some, as you can see, some just questions to make sure that trust boards are cited on maternity services, particularly around culture, listening to families. So we provided quite a detailed update to CGC around those actions, but we provided assurance that actually we've got a really good culture here and good processes to align to listening to our families and our staff. So those are the main points, Chair, but I'm happy to take any questions.
Sure. Any questions of Lorraine? Everybody's been rather quiet today, I think. Oh, Fiona.
Yeah, I just wanted to add really to the report that we had a visit from the LMNS, the local maternity and neonatal unit yesterday as their regular annual inspection or engagement visit with us, and I'd just like to give the board, ahead of the formal report that will come, a positive news story. Really, it was a very positive visit with lots and lots of positive feedback, and I'll mention a few. Staff felt supported to undertake improvement ideas. They felt that the leadership team were available to them, that they could speak up and ask for support when needed. patients and relatives felt that they were supported to make decisions together with staff and given information to do that. Trainee feedback was good. And care was personalised to the women and families that we care for. So lots and lots of positive. A couple of recommendations which we already knew. So a further work on reducing some staff anxiety and understanding of the new EPR system. Obstetric workforce review, which Lorraine just mentioned, and a review and extension of our continuity of care and model in the community, and then kind of an enhanced continuity of care model being one that they were recommending, but we'll work on that in the near future.
Thank you, Fiona.
Thank you.
It's good news about that visit.
Yeah.
Pramjit.
Well, thank you, Chair. Lorraine, thank you for that overview. It's good to hear about your ethnic recording, because that has been an issue that you say you have to resolve. What is the rate now? How complete is it? I know that might be putting you on the spot here.
So as part of our CNST compliance, so that's maternity safety standards, there is one that's dedicated to reporting ethnicity, and we were having to manually do that, and we were still above the 75% rates, but we were manually pulling that. So we've been able to now work with Badgernet to be able to do that electronically, and our rates are between 80 to 90%, fluctuating on, it depends on in month how many births you've had, what your percentage, but we're above the national average of what we need to be on an ethnicity. But also we any reviews that we do of incidents or anything like that, we always look now as part of that as ethnicity, as well as all the 10 special characteristics, to make sure that we're looking particularly across all health inequalities, especially particularly on ethnicity, but all characteristics as well, and that's part of that reporting process.
Thank you, Lorraine. Thanks.
Thank you. Any other comments from Lorraine? Isn't it sad that we seem to have trained too many midwives now?
It goes round in cycles, doesn't it, David?
They do, doesn't it? Yeah, it's one of those sort of, anyway, that's not in either of our gift to solve that one, is it? On that point, shall we move on? Thank you. Patient experience quarterly report. Is that you, Fiona, again?
Yes, sorry, just distracted for a moment. So this is a summary report of patient experience metrics. And many of them I've already talked about in my integrated dashboard report. But again, friends and family very positive in terms of feedback from the patients and around their care, but number of responses low, and we're doing some work around that, and again the response for complaints, formal complaints being responded to in time. But just a further assurance really in the back end of the report around quality improvement projects that come from feedback, and again just stressing to the public that we really do take their feedback very seriously, and we always try and find the learning out of there and put improvement work in. So we do really want that feedback. Thank you.
Any comments? Questions? No. I mean, in terms of the feedback from patients, I mean, is there anything more that we could do to increase the amount of feedback? Because, you know, we learn from both negative and positive feedback, don't we?
Yeah. So there's a number of things. So as I've said earlier, our patient experience team is fragile at the moment, and we're asking for mutual aid from George Eliot to not only support them in their function, but also to review how they manage patient experience and whether there's any additional learning. We're engaging with the volunteer team to see whether there's any patient experience volunteers that could go out seeking that feedback and supporting patients to fill in the FFT, and we are working with the ward managers in their CQC kind of well-led prep to say how could they more proactively either resolve issues at the low level so they don't become complaints, but also proactively ask patients on a regular basis, almost becoming habitual in terms of their routine work, as asking for feedback in person, so that we can either improve it in person or we can take it away as an improvement topic for each ward. As you know, in the 10-year plan, it talks very much about taking patient feedback rather than FFT locally into a more global system, and I wait to see what that is, but you know, it doesn't distract. In fact, it strengthens the need to do that local resolution and individual contact with patients. And I've been talking very much about patients, either in acute and community, but obviously Sophie's team works with the public in terms of feedback, which just adds a different dimension to it.
Yeah, I mean, I'm particularly mindful because in the future, we may well be measured by patients' perceptions of outcomes. And it's how we actually record that, or at least pick that up before we suddenly get the data come back to us later, because I think we need to be proactive on that, because of course it is the patient's perception of outcome that's the most important aspect. Really. Yeah, Sophie.
Thank you. What amazes me sometimes is like how complex some of the complaints are as well. So when you see that we're not hitting kind of the target we've set, often I'm aware that that's due to like the complexity of and the robustness, I guess, that we put into responding to it. I was just thinking though, based on the patient story coming to the board workshop, whether, Fiona, we could, just picking up your point around improvement, whether at improvement board we could start looking at complaints. So like pick a complaint out and run it through, and then what that improvement was, just so we can sort of then use our communications colleagues to start doing that. Because I think when you look at the performance against that turnaround, it doesn't really represent how seriously we take complaints. And so I just thought maybe that's something we could look at doing.
Yeah, certainly we could have a conversation outside of here how that ties into patient experience committee, because we've got one of those, and I wouldn't want to duplicate the conversation, but yeah, definitely turning it into improvement would help. And you're right, the complexity of complaints has really increased, and the accessibility. We used to have letters, handwritten letters, and we now just have emails, you know, the public are writing emails to the patient experience report that are very complex. But we have in our policy a clause that allows the investigator to contact, or actually asks the investigator to contact the complainant, say this is a really complex one, it's got primary care, it's got UHCW, it's got SWFT care in this, it's going to take me longer than the standard 25 days to respond, can I negotiate with you that it'll take me 6 weeks or whatever. That part of the policy is not being undertaken, and so we're setting ourselves up with a standard complaint response time that we could renegotiate with some of those complex ones. So that's the bit of work that we need to unpick.
And I think you've alluded to this though, Fiona, that you know, us now sharing executive with George Eliot, we may actually be able to learn from them, because clearly we both have to accept that George Eliot has been doing this more effectively than we have. And so I think this is definitely an area we can learn from our colleagues. I nearly said new colleagues, but they've always been our colleagues, haven't they? But I think you know what I mean, George Eliot. Anything else on this? Sophie again.
Or just building on that, I guess, as well, becoming an integrated healthcare organisation, there's an opportunity not just to do with this, but all that public engagement as well, working with our governors and other colleagues around how we just do a bit of a step change. Because you're absolutely right, it's like, I know I've seen examples in Birmingham that are really powerful in terms of how they do some of this. There's a bit of an opportunity for us to sort of step up a little bit in this, I think.
Yeah, I think this is one area where we very definitely need to be humble and say we need to learn from others. Very definitely. Anything else? No? Adam, Improvement Board update.
Thank you very much. So the report shows 3 months worth of Improvement Board updates. I'll take it as read, but just a few highlights for the board. I'm really proud of the continuous improvement culture we've got here, and the report highlights in particular the work we've been doing with NHS Impact through Improvement Board. We set ourselves a target of having 30% of our staff trained on improvement, and we achieved that. And more importantly, I think than that, when we look at the staff survey results and the responses our staff give about their feelings and senses on improvement, how willing they are to be involved, how they feel they can contribute, the responses are good and improving. So I think that's a really good news story and highlights the culture that we've developed in the organisation. There is further work we're doing on that, including developing improvement coaches over the next year, but great work across the organisation. We've also done a number of reviews to support future work. So, for example, we reviewed a DNA outcomes project, which resulted in nearly halving DNA rates in the area of the pilot. So, good work there. It also highlights reviews on the PSERF framework and the work we've done on prevention. And finally, one of the roles of the Improvement Board is to review business cases and particularly review return on investment. And in the period, as detailed in the report, we've looked at robotic surgery, the radiology investments we've had, and the MediConnect system we implemented. I'll leave it there, but I'm happy to take any questions.
Any questions? No. I mean, the only one I'm telling is about the robotic surgery update, Adam. I mean, are we underutilising an expensive resource here? Or is there some way we could make it? I'm just, because the whole purpose of robotics is not only to make the surgery more effective, but it's also to be more efficient.
Yeah. So I think that's a complex question, David. If the question is there more we can do with robotic surgery, I think the answer is yes. But there are complicating factors like the cost of consumables for robotic surgery. We're working through that. We're understanding what areas we can develop into in future, and we're working with partners. So I do think there's more to come from robotic surgery, but it's not as simple as saying, let's do more from next week.
No, it was a bit of a devil's question, really, because I sort of knew the answer, but it does seem that, there's this new technology that some hospitals are utilising enormously, and I'd hate us to be missing a trick on that. I think, Robert, you put in that the post-project evaluation is positive. Is that right? You want to enhance that statement, Robert?
Well, just to say, it's just really great that we do it. There's so many organizations that pass business cases, make the investment, and then don't return to evaluating whether it achieve its objectives. And then the other thing I was commenting on is that reduction in DNA. So I think that's really good.
Yeah, and perhaps just to build on that. Sorry, David. That pilot project did a great piece of work on identifying groups of patients that we felt were more likely to do DNA and contacting them directly. There's a real role for technology in that, and we always talk about pros and cons of AI, but there's a great case for the use of AI in identifying those cohorts of patients here and saving our staff time. So that's the next stage of that work.
On that point, Adam, have we got any information from elsewhere where AI has been really effective in that, so that we could learn from?
Yeah, so there's lots going on with AI. We've established a group AI learning group effectively, and as the four trusts in the group, we're working together, looking at both the work each other has done. There's been some fantastic work in Wye Valley, but also looking beyond that and what's going on across the country and what we can adopt quickly.
Yeah, you were ahead of me. I'm more concerned. Wye Valley does seem to be somewhat ahead of us, doesn't it? And it's rude for us not to take advantage of their experience, isn't it?
Absolutely, we're stealing indiscriminately from them.
No, it's flattery. I would love us to copy them. Heidi has a lot to answer for, doesn't she? If it's a she, and then let's perhaps not go there. But I think that's an area again we need to utilise our foundation group to its maximum, don't we? Any other questions on this? No. Sue, freedom to speak up. You're still there? Yes,
Thank
you
you.
are.
Yes, I'm here. Yeah,
I was
couldn't
saying you
unmute
were here at
myself.
the start, so I didn't think you'd disappeared. Hi.
No, thank you, Chair. So I'll take the report as read as usual. And first off, thank you to my team for picking up the slack while I've been off in what's been an incredibly busy couple of months. And thank you to those board members who have been in touch outside of the meeting as well to make suggestions for the report and to engage with us as a team. That's always really useful. A couple of highlights from the report and to pick up really on other things that have been said during board. So we talk about safe staffing, about sickness levels, patient experience, health and safety. They're all things that we try and triangulate as well. So when we get concerns from staff, we will look at the area that they're in and try and triangulate with other data. So we work really closely with the multidisciplinary team, with our health and wellbeing colleagues, OD, EDI, look at the patient safety stuff as well to see what complaints have come in, what in phases, datexes there have been in that area. So there's quite a lot of work that goes on behind the scenes when we get a case to sort of look at, well, what is happening, what is the bigger picture, and are there some wider themes and trends? And I don't know if that always comes across in the raw data and in the report, but it's important to say that. And we also have regular meetings with key individuals like our exec team, our non-exec lead as well, and also people like our Deputy Director of Nursing and some of our AQs, just to look at what is happening in that area, what are we doing as a response to these speaking up cases. And David, you just mentioned about patient feedback and outcomes being really important as a metric, and that's true for us in Speak Up, but our patient are our staff. So they're our clients, our customers, and we try and look at what's your satisfaction rate of going through the Freedom to Speak Up process. We don't get a huge amount of engagement in that. So at the moment, we've got 125 cases that are live across SWFT and George Eliot. And we probably get about 20% of those staff who will fill in a survey form afterwards to say whether they're happy or not. And the majority of feedback is really positive about the Speak Up process. What isn't so positive is the outcome. So they're not always happy with the outcome, or it's not the outcome they would like to have seen. In the confidential board and also at places like management board and in our exec meetings monthly, we talk about the cases in more detail and we provide a summary of cases, and that's RAG rated. So where you see ambers and sometimes reds, that's sometimes where those come from, because the staff outcomes are not what they would like to have seen and there's still some nitty-gritty issues. On the positive, for Speaking Up, I've not been around for a couple of months, but it's been extremely busy, and we're in the middle of planning for October. So our October's Speak Up week, as it is now, is empowering, enabling and embedding change. And we've got some really exciting speakers coming to talk to us and really looking at how we move forward with Speak Up cultures in the organisations, how we try and prevent that closed culture from happening, and how we really embed change. So it's really nice to hear other people talk about embedding change as a result of incidents and complaints and things. And then we've also been invited to speak at an NHS England conference in October, which again is looking at sharing, leading the way. And it's nice, I guess, because as a trust we are seen as one of the best at Speak Up cultures. And we are constantly asked to attend other things, provide information on how we do stuff. But then for myself and Deepa, we sit there and think, oh, we still feel like we've got loads to do. But we help other trusts wherever possible as well. So pinch with pride is our motto and share. Other than that, I'll take any questions.
Adam.
Thank you, Sue. Thanks for your work and welcome back. It's good to have you back. I think it's great to see our numbers of people speaking up remain high, and I think that is reflected in what you're saying there, that we are an organisation where people feel comfortable to do that. Though it is disappointing that our highest area of concerns is still in that attitude, behaviours and relationships category. And if Russell were here, he would no doubt say that's not what people don't come to work to feel that way, and people don't come to work to behave that way. And so there is something we need to understand there. We've implemented Speak Up training and we've implemented civility training, which I think helps in those areas. But is there more you think we should be doing there?
we were having this conversation with our ambassadors this morning, because we were saying, despite all of the fabulous health and wellbeing initiatives, the support that's there, all of the training that's available, still we get grumblings about behaviours towards each other from our staff groups. And I guess there's some work going on in the background about the impact of the work we do and the moral injury and the type of things that we see all of the time working in healthcare, and that it's actually quite a risky place to work in terms of your own mental health and well-being, and whether there's some more that we can tease out of that to learn and implement. So certainly measuring the risk and trying to mitigate it is something we're looking at, and working with our colleagues like Sam from the health and wellbeing team and our clinical psychology team on that. But if you find a way of getting staff to just be kind and nice and compassionate all of the time to everybody else, then, you know, that's a golden nugget, isn't it?
Fiona.
I am concerned and worried that this is going to get worse. So as we reduce headcount, which is a target, as we increase productivity, which basically means work harder, and as we expand our management capacity across 2 organisations, I think this is a real risk to us. And I don't know whether the right message, so not to contradict you or to push back, is you've got to be kind and nice all the time, because I don't think that's achievable. I don't think I'm kind and nice all the time, but I think, you know, it's about recognising when you are stressed and when you do speak wrongly, and then fronting it and apologising and explaining this is where I was at the time. I wonder whether a slight change in message to say we're not perfect, none of us are perfect. I don't expect perfection in patient care, let alone staff to staff attitude, but I do expect people to have insight where they have behaved wrongly and to apologise.
Yeah, sorry Fiona, I agree, you can't be kind and nice and compassionate all of the time, can you? We're only human.
Yeah, we do sometimes have unpleasant messages to put across that somebody isn't going to like. Ashley.
Thank you, and thanks, Sue. And I guess building on that, and really kind of from your feedback around when staff are given outcomes that it might not necessarily be what they wanted, and it's around how to manage those expectations through the process, which isn't necessarily a role for the guardians to play actually, but around we will look into it, take your concerns seriously, and this is the outcome and the reasons why. And I think that's the area we probably could be better at in terms of explaining that outcome and communicating it. And sometimes we don't even communicate it back to the individuals, or we hide behind that cloak of confidentiality, which of course we need to respect, but there's still ways of being able to feed that back. So I think that's probably one area as well where we could probably do more on to support yourselves as the guardians in terms of closing down cases, but also supporting those individuals who have raised a concern, have been brave, who have, you know, stated if something isn't quite right, but actually managing expectations as well. And then the other area around that, because a lot of the concerns that you get tend to be around the attitudes and behaviours, is around that kind of support and investment from the HR team as well, and helping to kind of resolve issues informally or helping with mediation. So again, you know, we get to a position where staff feel that there has been an outcome, there have been heard, there is going to be a change without the need to have to go through a formal process.
Oliver.
Thanks. Yeah, I mean, I agree with all that. I was just kind of reflecting on what Fiona said, and I think it's such an important point, isn't it? That you know, there's going to be more and more stress in the organisation, and you know, with everything going on, you could like productivity. You can add EPR to that as well. You can add the integration to that as well. You can add all of the what's going to be the impact of the 10-year plan and everything to that. And I wonder whether there's anything in terms of the communication, not just specifically around freedom to speak up, but just more in general about, you know, from the management team, from us saying, look, let's be honest, it's going to be a really tough time, and let's give people the permission not to feel great about it all the time, but to be able to talk about it, because I think one of the things that you said, Fiona, which I think is, it's about specific instance, but it's more about in general, isn't it? Like, people will be stressed in general, and that will lead to more, probably more sickness. And I bet if you track the trend of this versus sickness, you'd see something very, very similar, wouldn't you? So it's like whether there needs to be any additional communication around, it's going to be a tough time. We recognise it. We're working together. Let's get through it together, and recognise we're not always going to get it right.
Yeah. Well said. I mean, I think actually you were quite right. We need to manage the expectations as well, and some of that is communicating where, we know it's going to be tough. Sophie.
Yeah, and I just wonder if it's an opportunity to go back to the values of the organisation. We've done a massive exercise on that. We haven't revisited that in a while. You can do these difficult things, I think, in line with the values that we've set out as an organisation, and it gives you a framework to be able to then challenge when that's not aligned to that. So, new HR people, exec, it's probably a good opportunity for us to rethink that in the context of the environment we're heading into.
And thanks for that offer, Lee. I see in the chat, which I think we should take her up on that. Very much so. Anything else on this one? Anything I'll say is I'm going to make myself really unpopular with my NED colleagues. It does add to the assurance, doesn't it, when there's a NED executive summary as well as an executive summary. Maybe we should think about that for other reports, but perhaps you're ahead of the game, Sue, as usual on that one, I think. Anything else? No? Let's move on. Robert, Audit Committee reports.
Yeah, okay, thank you, Chair. Be pretty brief with this. 2 meetings to bring a summary to on the 9th of July and the 31st. Because of the time of year, as you'd expect, a lot of the content is focused on the annual accounts and the annual report and the quality report and the annual governance statement, etc. So it reflects a kind of iterative process where we took those for review on the 9th of July and then a further set on the 31st following the conclusion of the audit. So that's all gone through, and they've been approved by the board, as you know, and will be publicly presented to the public in October. What I really want to do is just take the opportunity on behalf of the committee to thank Kim and her team for all of their hard work during what was a complex and drawn out audit, and they did very well to meet all of the auditors' requirements for information and to work through some very complex issues, and particularly to keep the audit committee briefed on the approach that we were taking to certain issues and having us apply the necessary governance to that. So that was it, Chair. A good conclusion to the year.
Any questions of Robert? No? Moving on to the Clinical Governance Committee reports for 9th of July and 13th of August, and that's got my name on it. I think, again, I'll take these as read. The one area that, well, there's 2 areas I want to highlight. One is that the assurance regarding the CQC action plans being on track, which I think is worthwhile the board taking note of. But the other is the actual concern related to pathology turnaround times, relating and the risk that it's caused. And I have to say there was considerable debate at this particular governance committee about that, with the pathology committee, Committee on Warranty of Pathology Services being present, and I'm not entirely sure we were completely assured that they were thinking in the same way we were. So I think that's something we need to highlight. I know it's come out at other parts of the reports as well, and the impact this has on all of the hospital services, but particularly the cancer targets is important. Any questions of me on this? Fiona?
Just as an update really around the CQC action plan, it was all on track, but the appraisal has now gone off track. and that was what was alluded to in Ash's report earlier. There's two elements actually. There's an appraisal overall, which we're not hitting our target, and we do need to do recovery work on, and to assure the CQC that our staff are having appraisal and are safe to practice. But the other is mandatory training, particularly for our medical colleagues. So again, we're doing some focused work on that, but I am concerned that both of those two are a risk to CQC compliance.
Yeah, I mean, in my defence, I was writing this relating to July, not current, but point well made. Anything else on this? No. We'll move on. Summary of ratified policies. Adam.
I will take it as read, Chair. 2 policies ratified this month: family leave and missing patients over 16.
Yeah. Any comments? No. Right. And Sarah, the updated registered directors and registered directors' interests.
Thank you. I'll take it as read, but just to note that the interest that Ollie declared at the beginning of the meeting has been captured on the register.
Excellent, excellent. There's also board committee meeting minutes for the audit committee for the 2 meetings. Robert, anything you want to add to those minutes?
Nothing to add, Chair.
No,
nothing.
But similarly for myself with the governance committee, I've got nothing to add. So we're a bit ahead of time, but any other business? I have one thing to say, but I don't know if anybody else has. No. It probably most people won't realise Dawn has been working in the background as the board. I forget what the official term for her title is, but anyway, effectively she's been the administrator of the board for some considerable time, and this actually will be her last meeting in that particular role. Now I've known Dawn for a long period of time, and I've always really enjoyed working with her and hope to continue working with her, to be perfectly honest, in the future. But I think it would have been remiss not to actually make comment on her last board. So from me, thank you, and hopefully from the trust board, thank you, Dawn. And at that point, can we move on then to questions from governors and members of the public? Sarah, have we got any?
Sorry, I was putting in the chat to Dawn, got distracted. Thank you. So we have had one question submitted by a member of public who asks, what are the trust plans for increasing compliance to the 92% standard of patients seen in 18 weeks from referral to treatment from the current 66%? Would they consider liaising directly with an insourcing company for support at fair and equitable shares of tariffs? Harkham, I was going to answer the question. Thank you.
Thank you. So a couple of board reports ago, I did put in an RTT summary to talk about getting us back to so where we stand from an RTT 18-week perspective, and I provided assurance of how we're doing against our long waiters. You'll remember for many months now, I've been talking about the pressure that we felt with orthodontics, and they formed most of our long waiters. We've managed to solve that now, so we don't have any patient waiting over 65 weeks. We do currently have a problem in terms of patients waiting a long time for dermatology, and they are forming quite a significant backlog in terms of patients over 52 weeks. But we do have an eye on that and a trajectory, so we are working to fulfil our obligation to bring down those very long waits and get back down to under 52 weeks. And I've shared those trajectories in previous meetings, but just to provide assurance, we absolutely have our eyes on 18 weeks. It's just still insane, I think, that we talk about 52 weeks and, you know, we should be saying a year. It's such a long time, isn't it? In terms of the insourcing element to the question, we do insource as and when we need it to fill in some urgent gaps. So we've done general surgery, we've insourced for ophthalmology, both were really successful. And that tariff share agreement is exactly how we modelled the contract, and then actually we exceeded the activity and income targets that we set out in the original business case. We've also insourced for ENT, which was more of a hybrid approach in terms of how we worked with that company, and there were definitely lessons learned. And I think that both parties would go back and do something separate. But we are actually working with that same company now, who are supporting us with dermatology, and they start insourcing from the 6th of September. So we will do whatever it takes to clear these waiting lists, and very often private providers or independent providers are much better suited to parachute in and provide that capacity, as long as it meets all our clinical governance guidelines, and we can sort net off like the income and activity element of it. Absolutely, we will continue to do that.
Thank you for that. We've got another. Any other questions from members of the public or governors? No. Thank you for all coming and attending. We've finished this meeting a little early, but perhaps that's going to be helpful because our confidential is rather lengthy. Can we call the meeting to a close now? The public bit of the meeting. Shall we have a brief break for those of us to come back at confidential? Perhaps what, 5 minutes or 10 minutes? 10. I see. Sorry, there was a discussion in the workshop about how long these breaks should be. We'll make it 10 then. So it's 5 minutes past now. So if we say 1:15, and we all reconvene. So thanks very much. See you there. Bye.